Testing, testing, 1, 2, 3, 4. Hello, Dr. Angelini. If you could mute, unless you have a question, if you could mute your mic, then we won't get the echo that we're receiving.
All right.
Thank you so much.
My pleasure.
I would like to introduce, we're still getting rebound there. Tell you what, we'll mute from here.
How about now?
Testing 1, 2, 3. Testing 1, 2, 3. Still getting rebound.
What do you think about maybe turning off?
Do you think it's from me?
I think so.
My technical people are temporarily out of the room.
Okay. All right. So have you muted yourself there?
I can mute myself. I think so.
Should be something to mute yourself. Usually I can mute
Like
you.
this?
I can't mute you for some reason. I've got mute all. Okay. Testing 1, 2, 3, 4. Testing 1, 2, 3, 4. We don't hear it. It's okay now. So I think we're doing okay. Except I muted myself. That's why. We don't hear anything. Testing 1, 2, 3, 4. Now I'm unmuted, and we don't have an echo, so we're okay. So
Can you hear us?
Can you hear me now? Can you hear me? You'll have to unmute yourself to tell me you can hear me, or else you can send me a message in the chat area.
An hour goes by, and he's like, "Have you started yet?"
Type me a message. So how do we know that they can hear us? We don't. And let's see. Let's do this.
Mm-hmm.
I'm typing a message in to see if you can hear us. If you can type back and let me know. I just sent that to you. Can you hear us? Can you hear us? Testing 1, 2, 3. Can you hear us? If you can type in that you can hear us, then we'll know.
Dr. Angelini, can you hear us?
Testing 1 2 3 4. The mic's picking up. Testing 1 2 3 4. Testing. So
Now we just need to
the mic is
check
picking up.
to make sure he can hear us.
Okay. Testing 1 2 3 4.
5.
6.
Hey, Dr. Angelini, can you hear us now? Dr. Harrison's calling your phone just in case we haven't been able to get in touch with you.
Okay, I've got to where we can see that you said you can hear us. So I found that. And then you said we are muted but do not hear now, Dr. Angelini, 517, so it's 518. Could you signal one more time that you can hear us, and we will start, okay? Testing 1 2 3. Please signal you can hear us. All you have to do is write a question, and then we will start. Hello, John. It's nice to have you. Thanks for attending. We can hear you. Okay, we're going to start our presentation then. I'd like to introduce Dan Bali, who's our fourth-year medical student. He'll be presenting with Dr. Alberto Morales, and we have multimodality imaging of a very interesting case of Takotsubo. Dan, take over.
Hi, this is Dan.
Get this out of your way.
Maybe scroll back up to the top. Yeah, you can move that out of the way. There you go.
This is how we do it. Okay. So today we present to you Miss X, who's a 52-year-old Caucasian female who presented to the clinic with a 2-day history of shortness of breath, chest pain exacerbated by deep breathing, nausea and vomiting, heavy feet after a 15-mile bike ride. This is quite unusual for the patient since she is very active and exercises about 6 hours per day. She's also complaining of weakness, and she reports a recent URI after a scuba diving trip to the Bahamas. Since then, she's been having a feeling of full feeling in her head, which is accompanied by headaches. Also, she reports recent stress, which has been significant, and she has been developing elevated blood pressure along with the stress. She reports a similar episode a few years back where she was experiencing a lot of stress, which was also associated with elevated blood pressure. So, review of systems as above. Her past medical history is insignificant. Surgical history, appendectomy and cesarean section. Family history, her father had a stroke and hypertension. Mother also hypertension, as well as the brother. She does not smoke and drinks about 2 drinks 3 times per week. On presentation, her vitals were blood pressure 132/98, which is an increased blood pressure for the patient. She usually runs around the 100 systolic and 60s diastolic. Her pulse was 112 per minute, and she was satting quite well at 97%. On physical, neck was supple, lungs cleared auscultation bilaterally, heart regular rate and rhythm, S1, S2, no murmurs, rubs, or gallops. Abdomen was soft, non-tender, no bruit, no masses. Extremities, radial pulses were 2+, dorsalis pedis 2+, no edema. We did an EKG of the patient. She is in sinus rhythm, and hello? Okay. Sorry about that. Normal sinus rhythm, except we see a quite angry EKG with inversion of T waves in the lateral and inferior leads. Is there anything else we'd like to mention? Okay.
Does anybody have any comments on the EKG?
Be muted, or can I talk?
You can talk now.
All right. Yeah, this is an EKG of an acute Takotsubo, 99% probable. No QRS changes, but deep T-wave inversion and prolonged QT is very typical. This is usually 1 to 3 days after onset. You hear me?
Yes, we can hear you. Do you have any? What do you think about the subtle ST elevations?
Yeah, it's very typical. It's not the very acute phase. Usually there is a phase with more obvious ST elevation like in V2, but eventually everything is ST depression, prolonged QT, and a gradual resolution of the negative T wave over a week or 2 weeks. This is definitely consistent with Takotsubo.
Now, can you also diagnose pericarditis from this EKG?
No.
Okay, thank you. So afterwards, we did a limited echo of the patient's heart. I think we have some images for that.
Do we have images of the echo, Dr. Harrison? So we did a limited echo at the time. This is a patient who actually works here in our clinic, and and had these symptoms, and we did a baseline EKG on her, and we found these symptoms, this abnormal EKG. In the face of these symptoms, we quickly put a probe over her chest and found significant wall motion abnormalities in the anterior wall and apex, and we quickly rushed her, obviously, to Tampa General in view of the EKG changes for suspected ACS. We did not do a full, complete, comprehensive echocardiogram at that time, and so we'll go ahead and move on to the cath results.
So first, upon entering the ER, the patient had labs drawn. No significant abnormalities, maybe some lower H&H platelets at the lower level of normal. Now, we have the cardiac cath. We're going to pull that up now.
Bear with us one moment. We're trying to pull up the cath report right now, the cath images. We seem to have gotten disconnected, so we're having to start a little from fresh. Sorry about that.
Okay, we've got the emergency cardiac cath, and as you can see that there's limited wall motion by using the coronary artery as an epicardial marker. You can see there's limited motion in the distribution of the distal LAD, and it looks like the motion is limited from right this point where there's that elbow or that hook there, and then there's limited motion in the distribution of the diagonal vessel as well. The septal perforators look like they're moving pretty well, and the distribution of the circumflex is moving well. And so this is another injection that again shows limited wall motion by using the coronary artery as an epicardial marker, limited wall motion of the left anterior descending and the diagonal vessel, and you follow the diagonals out. Even this branch has limited motion. So this whole segment does seem to have a coronary distribution. Frequently it's said that it doesn't match a coronary distribution, but this matches quite well the distribution of the mid-LAD diagonal system. So let's look on at some more of these images, and then we'll let Dr. Angelini comment. And so, of course, we're not seeing any obstruction on careful examination. And we're looking at the right coronary artery, which has very vigorous wall motion. It appears to be in all parts. It's hard to tell about that posterior descending down there. because it's coming towards you.
The right ventricle is moving well, man.
And so down here, there is right ventricular motion. Posterior descending looks like it's moving pretty good up until just maybe the little distal part of it there may not be moving as vigorously. So that could be sort of riding a little slower. And then here's our LV gram, probably with the hand injection, and that looks a very beautiful expression of the octopus pot, as you see there. And the wall motion goes beyond what you would expect from the LED, because this inferior apical area seems to not be beating. Unfortunately, we don't have an LAO projection to be able to see the septum and the lateral wall, but that does look like it goes beyond the expectation of the left anterior descending, where it comes up the inferior wall, and even a little bit of the lateral wall here that's superimposed doesn't seem to be beating as well either. So that would say that it goes beyond the vascular supply of the left anterior descending. But we'll see what Paolo thinks about that. We're going to give you back the mic, Paolo.
You're unmuted, Dr. Angelini.
Wonderful. So this is definitely a typical presentation from the symptoms, from the point of view of the EKG, and now from the point of view of not finding coronary disease at this stage, and a typical apical ballooning with a fairly symmetrical area of hypoakinesia around the apex. It's both the anterior wall, but only mid-distal, and the inferior wall mid-distal. So it's definitely not the territory of a single artery, but it is a territory of the whole heart around the apex. So it looks like it is neurogenic in character, in distribution, but we cannot say by this evidence what is the cause and the pathogenesis, but just guess that this is a neurogenic event. But eventually, how does it get to cause this type of akinesia is to be demonstrated with some more testing. Do you know at what time the symptoms occur before the test?
It was about 2 to 3 days, I believe. That's what, yeah. Hold on a second.
You see, in the first, if the patient had the symptoms on and was studied in the next 30 minutes or so, you could see narrowing of vessels. Sometime it was well demonstrated during a cardiac arrest or coming out of a cardiac arrest as the first symptom of Takotsubo, and eventually with nitroglycerin resolving that part of the pattern of coronary spasm, but remaining a case of hypokinesia of the apex. But you see very well that there is a dyskinesia or a hypokinesia of everything around the apex, both anterior and inferior, very symmetrically, like in a vase in an ampulla, is very typical. And there is on top of it a mitral valve prolapse that is obviously not new, but it tends to be more evident because of the hyperkinesia of the inflow tract of the left ventricle. You see how prominent tongue of the mitral valve prolapse. The echo was consistent with this picture?
Yeah, so she was subsequently discharged the next day, and being an echo tech herself, we're getting some feedback here. Let me mute you, Doctor.
I'll mute you. I get it. I got
we decided to get an echocardiogram here in the clinic, and it was very typical, very consistent. I don't have the, I do have the echo. It'll be a moment, but we do have a cardiac MRI that was actually done several days later that we'd like to show. One of the interesting things that we're going to show at probably on a follow-up visit is that this patient, being echo tech herself, has been able to get serial echoes on her heart on a daily basis and follow the resolution of her cardiomyopathy. And so we'll at some point put all these images together, including a post-cardiac MRI, which she's scheduled for next month, and hopefully be able to have something to write up and to follow the resolution pattern of a Takotsubo. So what I'm going to show now is some of the MRI. So this is a typical vertical long axis, similar to a two-chamber view, and you can see the very classic from a mid-wall to apex, relative pretty much severe akinesis to akinesis with relatively preserved basal wall motion. Calculation of the ejection fraction turned out to be about 44% with some mild left ventricular enlargement and no significant. This patient has a history of mitral valve prolapse and typically has a very nice posterior leaflet scallop prolapse, and it's with a nice mitral regurgitation that was not being able to be seen on echocardiogram. This cardiac MRI, probably likely related to this cardiomyopathy with some possibly some tethering and pulling. So this is a very nice classic picture. So with MRI we're able to do a little bit more. We're obviously able to perform some tissue characterization. So let me show some more images here before we move on to that. So here we have a, what do we have here? So here you can see, hopefully you start getting it on your screen here. There you go. So this is a sweep through, how do I minimize this? Okay. A sweep at the level of the base, all the way extending down to the level of the apex, a short axis wall motion, as you can see, relatively preserved at the level of the base, and as you start getting out toward the mid-wall and distal, mid-distal and apex, you get relative severe hypokinesis, akinesis. Let me cut this out. Here's a 4-chamber projection, and here you can see nice basal. The right ventricle is functioning very well. There's a little bit of left atrial mild enlargement on measurement, and a little bit hard, but you can see the apex is not moving very well, and the mid walls are not moving very well here. Left ventricular outflow tract projection, looking at the aortic valve, the right ventricle, anterior septum, inferior lateral wall, apex out here, and you can see again nice basal preservation with mid-wall to apical severe hypokinesis. One of the nice things we're able to do with MRI is calculate a pretty good ejection fraction, obviously, because we're able to take into account all the walls, whereas echocardiogram, oftentimes we calculate ejection fraction by comparing one wall to another wall, Before I move to that, let me get perfusion. So one of the things we do is assess for perfusion abnormalities. We obviously knew her; she wasn't going to have any perfusion abnormalities. So this is a nice case of normal perfusion. And so what we do is give a suppression pulse to darken the myocardium and everything around. And what you're seeing is gadolinium, which is bright, entering the right ventricle and then entering subsequently the left ventricle. And then what you want to see is a nice blushing of the myocardium where it turns this nice bright a significant area of ischemia would signal a subendocardial area of darkening, typically in a distribution of a coronary vascular bed. And we don't see anything here. So this is a nice example of normal perfusion. So once we give gadolinium, then we're able to assess viability and scar burden. And in patients with Takotsubo, we do not expect there to be myocardial necrosis, and thus there should be no scar. But we're able to identify patients who indeed may have had prior ischemic damage, may have myocarditis, may have other things. And interestingly, in this patient, so in viability imaging, the way we do it is we give gadolinium and we wait typically 10 minutes, and there's a nice, in normal myocardium, there's a nice wash in and wash out of gadolinium, and so by the time we image 10 to 15 minutes later, we want to see that the myocardium is nice and dark. And so nice dark knolled myocardium is what we expect the normal. And so areas where there's acute damage or scar burden, there's increase in interstitial space. And so what happens is the gadolinium enters at a slower rate and leaves at a slower rate. And so we're able to capture the gadolinium 10 minutes later due to the poor wash in, poor wash out, as well as enhanced extracellular space. And so that shows up as a bright area. And so as you can see here, this is a normal delayed enhancement, and the myocardium is nice and knolled, and there's no evidence of scar burden. One thing you do realize here is that there is this bright signal that surrounds the myocardium. I don't know if you can see that. That's actually the pericardium. And so what happens is the pericardium is actually an avascular structure, but when it gets inflamed and inflamed as in pericarditis, you get this neovascularization from granulation tissue and inflammatory cells that enter that space. And now gadolinium can enter, and it shows up as a bright signal that surrounds the myocardium. So this patient indeed has pericarditis in addition to Takotsubo. And so I guess the main question is, which came first, the chicken or the egg? And we'll talk about that as we move on through the talk. But this is the pericardium, as you can see right here, and it's nicely enhanced and bright, consistent with pericarditis as well in a patient with no scar in the myocardium, and obviously a cardiomyopathy with normal perfusion, which is consistent with Takotsubo. One of the other features that we can see, and let me show you another enhancement image before we move on to that, is, let me get up here. So this is a 4-chamber. And here you can see the myocardium is nice, and we can get a better view of that. But one of the things I want to highlight is here, look at this pericardium. It's nice and bright and surrounds the entire myocardium, consistent with active pericarditis. See if I can pull it up a little bit better over here. Okay, not going to show up as good there. So circumferential pericardial inflammation, and then we can perform T2 weighted imaging, which allows us to see edema in various tissues, which is very non-specific but very sensitive. So any type of fluid any type of fluid that is in the tissue, we can see it, and that fluid could be built up due to inflammation, infection, infarction, ischemia, trauma, whatever the cause may be. We can see edema, and it's nonspecific, but it tells us that there's been some injury. And so inflammation, one of the key components of inflammation is water in the interstitial spaces, and that's what we can see with cardiac MRI. And so here we have a basal slice. Oops. Let's see if we can pause that. So this is a basal slice, and this is normal. Consistency, normal intensity of the myocardium at the level of the base. Actually, I think I have better pictures. Let me see if I can pull those up real quick. It's probably in the slide, isn't it?
That one, yes. The pictures.
Yeah. Let me pull this one up. All right, so here's an axial projection, and I don't know if you can notice the as we get to the what's going on here. I don't know, as you can, it's going to scroll kind of quick here, I guess. If you can envision, here's the base right here. It's nice and dark, and as you spread towards the apex, you see significant brightness at the level of the myocardium. That's consistent with significant edema, and as you can see, the edema, see if I can catch it, the edema gets significantly brighter as you reach the apex. And so there's whatever the cause of this injury or insult to the myocardium, it seems to, and at least in this patient, that leads to significant more edema at the level of the apex than at the mid, and really relative preservation at the level of the base, which goes along with the actual wall motion abnormalities. Now we will go back to the slide, and I'll show you. Where's the PowerPoint? One second while we reload our PowerPoint presentation. I'm going to open it up to Dr. Angelini real quick and see if he has any comments.
Unmuted.
Am I on?
Yes, we can hear you.
All right. The question I had is, at what time was the MRI done? How many days after presentation?
So it was Tuesday when we did the cath, and Friday when we did the cardiac MRI. So we're looking at about 3 to 4 days.
Because it is quite interesting that the flow in Takotsubo in the very early stage is quite diminished. The myocardial blush is quite abnormal if you take the patient in the first few hours. In the next 1 to 2 hours it disappears. But the cases that develop a case of Takotsubo during dobutamine stress test are the wonderful example where you can really understand the process, because the initial injection during the dobutamine effect is when you actually get what we think is a spasm that causes ischemia. But then it goes away spontaneously or with medication quicker, in the next few minutes. Surely it will last more than half an hour to have stunning of the myocardium, but the ischemia disappears very quickly while the stunning remains. If it remains ischemic, the myocardium remains ischemic for 30 minutes or more. So it is the only case basically where you can have the demonstration of diffuse spasm and the demonstration of lack of flow in the myocardium that has stunning, because you're able to take a picture during the acute pathogenetic event, which is, we believe, spasm.
And so you think it's epicardial spasm versus microcirculatory dysfunction?
It could be both. It could be both. We can only at this time say that in 50 or so % of the cases for the first few days, we can reproduce this phenomenon with acetylcholine tests, and then it goes back to normality and negative acetylcholine testing after 1 to 4 weeks. So it seems to be very suggestive that this is the basic phenomenon, but we need more cases to substantiate the notion the spasm is at the beginning and the nerves are behind the spasm, most likely. What was the stressful condition in this patient?
So there wasn't one specific stressful condition. I think there was a lot of stress at home. A family member passed several months before, but that wasn't extremely stressful one-time situation. But the repercussions, the financial and family problems that developed subsequent led to a lot of ongoing stress periodically and daily.
Uh-huh.
And I think coupled with some infection. Here's the cardiac MRI, and you can see at the base normal intensity, at the mid sort of an increased signal intensity consistent with edema, and as you get to the apex, significant edema.
But this is not scar.
No, this is not scarred. This is edema.
Yeah.
T2 weighted imaging.
It was typical of a sort of midterm MRI that you had thickened myocardium. In the early phase, when there is more dyskinesia or akinesia, the myocardium is thin. At that time, it was more thicker than baseline because of the edema. But the thinning had already disappeared in great part.
Yeah, and there's that same image again showing the same consistency. And you can do certain protocols to assess for an inflammatory related, and some of the cardiac MRI discussion that we'll have in just a little bit, we'll talk about that. We'll go ahead and talk about what we did next.
So afterwards, we did the rapid infectious disease identification test, which tests for bacteria, protozoa. We did not test for viruses, but it came back negative for bacteria, so we did not find an infectious cause for this patient's Takotsubo. So eventually we found out the patient had Takotsubo. Now we can put a name on her. So let's talk about Takotsubo. It's a disease of many names. The first one coming from Japan, because the heart actually looks like a pot used to capture octopuses, hence the name Takotsubo. Afterwards, the names afterwards came from the way it was visualized via imaging techniques. Later on, it was named after the situations it was induced by, such as stress, hence the name stress-induced cardiomyopathy and broken heart syndrome. On presentation, the most common is chest pain and dyspnea. Others can be pulmonary edema, cardiac arrest, as you mentioned earlier, cardiogenic shock, arrhythmia, syncope, weakness, cough, and fever. The greatest association is with stress, as we said earlier, such as death of a loved one, public speaking, anxiety, stress testing with dobutamine, and thyrotoxicosis. Some of the complications are arrhythmias, ventricular rupture, mural thrombus formation, circulatory collapse, and sudden death. So pathophysiology, we're still unsure of the exact mechanism, but there have been many proposed ones, such as vasospasm, microcirculation disturbance, obstruction of left ventricular outflow tract, catecholamine-triggered myocyte injury, emboli with spontaneous fibrinolysis and regional myocarditis, and inflammatory/infectious. So we'll go on into the inflammatory aspect of Takotsubo. So there was a study done by Kawai where they took biopsies of hearts with myocarditis and Takotsubo. So the main differences they found were that inflammatory cells in myocarditis actually came in and damaged healthy myocytes, whereas in Takotsubo, the main role of the inflammatory cells was to come in and clean up damage after it was already done. There was another study which tried to develop some criteria for diagnosing Takotsubo with CMR. And they had a total of 90 patients with Takotsubo from 2 different institutions. And the patient characteristics were a median age of 71. Most of the patients were females. Most of them had a stressful event occur. There was a positive troponin. EKG had positive changes. Most of the patients had hypertension, and smoking and diabetes were not that relevant. Our patient, in fact, was 52 years old. She was a female, had a stressful event. We were not sure of the troponins because due to the presentation and all, they were not done. She did have EKG changes, as we saw previously, and she did experience hypertension. Now, the CMR results in the study were most commonly you would see apical ballooning. Secondly, you would see midventricular ballooning. Basal ballooning was not as common, as these findings are also similar in the general in other studies. The average left ventricular ejection fraction was 45. Our patient's ejection fraction was also 45%, and diastolic volume was 136 plus or minus 29, and systolic volume was 72 plus or minus 23. So our patient's results were quite similar. She did present with edema on her MRI, and late gadolinium enhancement was not present in 3 and 5 standard deviations. She did present with pericarditis, which was not mentioned in the study. I just thought we should outline that. So during follow-up 3 months later, most of the irregularities resolved. So ejection fraction went up, apical ballooning went down, edema went away, and ejection fraction went back to pretty normal. So other results on MRI were positive inflammation, which was measured with the Lake Louis criteria for myocarditis. They also showed pericardial effusion in 53% of the patient, right ventricular involvement, pleural effusion, and thrombi in a few of the patient, 2%. During follow-up, pretty much everything resolved. So the study conclusions were that you could possibly diagnose Takotsubo with just MRI. By typical patterns of mid and apical left ventricular dysfunction, edema in the mid and apical myocardium, absence of late gadolinium enhancement, and myocardial inflammation values, and also after after recovery, you could see left ventricular wall motion abnormalities resolve, inflammatory parameters, and late gadolinium enhancement go away as well. But of course, the diagnostic accuracy of these criteria should further be studied. So there was a good review article of a few case studies on pericarditis and Takotsubo to try to evaluate the relationship between the two disorders. So they came up with two hypotheses of how this occurred. So one of them said that due to the inflammation or maybe even myocarditis, the pericardium was affected through extension of the inflammation into the pericardium. Another theory was that the acute pericarditis caused the Takotsubo. But once again, further study is warranted to evaluate this relationship. So these are the case studies that were present in the review. So in half of them, the pericarditis occurred after Takotsubo was diagnosed, and in the other half, Takotsubo or pericarditis was found at the time Takotsubo was diagnosed. So basically, with our MRI and biopsy findings of Takotsubo, we can see that the inflammation has something to do with the with potentially extending into the pericardium. And it is important to recognize that pericarditis can be present with Takotsubo because of using thrombolytic therapy, which could potentially lead to cardiac tamponade or other.
And it has happened in one or two cases.
Yeah, and it actually happened in one of the cases. So right now we're using the Mayo criteria to diagnose Takotsubo. So basically you would see regional wall motion abnormalities. You would have an emotional or physical stressor. You would do a cardiac cath to evaluate for coronary disease, and you would try to you would find that there is no coronary disease usually in most of the patients with Takotsubo. Also new EKG abnormalities and modest elevation in troponin levels. And you also have to rule out pheochromocytoma or myocarditis. Now, as we mentioned, right now we're still using the EKG and the criteria, so ST segment elevation, nonspecific ST T-wave changes, prolongation of the QT interval, and as in our patient we saw deep symmetric T-wave inversions. This is the cardiac cath showing clean coronaries.
But you can see non-obstructive coronary disease incidentally.
Yeah, yes, but you can see non-obstructive coronary disease incidentally in some cases of Takotsubo. And here's the apical ballooning, midventricular and apical. On echo, you would usually, classically, you see apical to midventricular left ventricular akinesis, but there are other variants of the disease, which is midventricular akinesis with apical sparing, basal akinesis with midventricular and apical sparing, and a changing pattern of wall motion abnormality. So the significant points here are that inflammation does have a major factor in Takotsubo, as stated with the MRI and histological findings. Pericarditis needs to be evaluated further, as does infection. So, to our knowledge, we are the only institution that recorded the progressive resolution of the apical ballooning via echocardiogram. We were lucky enough to have that the patient was actually an echo tech, so she was able to perform continuous echoes on herself pretty much every day following her episode. Do you want to include anything else? Okay.
So hopefully at some point we'll be able to maybe give you guys an update as to the progression, the follow-up, and the repeat cardiac MRI, and maybe have some more information for you. At this time we'll turn back to Dr. Angelini for comments. You are unmuted.
Thank you. Thank you. I think the message that is coming through in the presentation is that pericarditis is frequent in Takotsubo. And this is not known to me and not very clear from the literature I know. Having some tendency in minimal, like in this case, I think, amount of pericardial fluid is not unusual in acute infarction, but pericarditis is more than pericardial fluid. And I wonder how sound is the diagnosis of pericarditis in place of just mild pericardial effusion, is in your opinion at the end of one case experience?
So are you, I guess what we're trying to understand is, are you talking about in cases or in this case?
Katsuba, I understood that in your general presentation you made a case of 50% of the cases of Takotsubo having pericarditis. Is that what you represented?
No, so there was, we searched the literature and we didn't find that there is a strong fixed association of pericarditis with Takotsubo, but we did find that it's not uncommon to find pericarditis in patients with Takotsubo. And what there's not extensive literature on that. We found roughly 9 case reports reported of patients who are found to have not only Takotsubo but pericarditis. And the diagnosis of pericarditis wasn't always made by cardiac MRI. It was made by exam, EKG findings, presentation, and in some cases the pericarditis was thought to either be present before Takotsubo, in some cases at the time, and then roughly about 50% of the cases that were reported of the 9, albeit, the pericarditis was diagnosed after, following. In this presentation, patient had some pleuritic component to her chest discomfort, and at the time, this I think had been getting a little worse, and the thought was that she could have coinciding pericarditis, but the EKG was obviously, consistent with either some sort of ACLS-like syndrome, and so once we got to that diagnosis, we decided to do a cardiac MRI, and the thought was that she could possibly have pericarditis, and sure enough, she did have pericarditis, and you can see that very nicely on delayed enhancement with significant enhancement of the pericardium. And so we found 2 things in this patient, and so that prompted us to do a literature search for looking at incidence of pericarditis in Takotsubo and its association. And at this time, it's not very clear whether or not they're incidentally found together, or that pericarditis could trigger possibly pain and catecholamine surges similar to what we've seen in other patients, or that maybe the whatever insult that led to the Takotsubo also led to some secondary inflammation to the pericardium. I think what we've read in the literature is very unclear, and obviously everybody who's written about it makes the very claim to fame that more information, more research needs to be looked at. And so we're just simply, we're not implying anything, we're just bringing up something that would be knowledgeable and helpful to understand. There was 1 or 2 cases where patients were presented with chest pain and had dynamic T waves and ST changes, and they got glyco-2b3A and heparin, and they ended up with pericardial tamponade due to hemorrhagic pericardial effusion. So I think making awareness known that the 2 could coexist and there may be possibly a relationship is very important.
Unmuted.
Yeah, the only structural secondary pericardial effusion that I know in Takotsubo is from rupture. But pericarditis has been an intrinsic manifestation of Takotsubo is basically ruled out by an overwhelming experience of thousands of cases that have been seen. It is not frequent, it is not, if not occasional, that you can see pericarditis. But it's important to change the terms. Pericardial fluid versus pericarditis is quite a difference. If you have only a little fluid, and I don't know if you can call this, for example, something like 50 or 75 cc's of pericardial fluid in the early stage of Takotsubo, is different than if you have a pericardial rub. That's an important thing. Or an hemorrhagic pericardial fluid, that's an important change. But those are different than pericarditis.
Yeah, and I agree. Right now, at the time, the diagnostic criteria for pericarditis diagnosis is really if you have 2 out of 5, one being the classic chest pain syndrome, classic EKG changes, pericardial rub or friction rub, and then a pericardial effusion. So right now, at least right now, it's in the diagnostic sort of algorithm for diagnosing pericarditis. I see, trivial pericardial effusions all the time, and sometimes in patients who indeed have pericarditis don't have a pericardial effusion. So it may be sensitive, but it's very nonspecific, just like you say. And so I have found cardiac MRI to be very useful in patients who have rip-roaring pericarditis with minimal symptoms or very lack thereof of clinical features to diagnose it. And we've been able to diagnose a lot more cases. And so I agree with you. I think just a simple pericardial effusion could mean a lot of different things. I think as you start seeing more, material with the pericardial, such as a hemorrhagic effusion and so forth, then you start becoming more specific. But it's very difficult at this time, just with a trivial or small pericardial effusion, to attribute that purely to pericarditis.
Unmuted.
Excellent presentation. Thank you. Is Eric still there? No.
Yes, do you want to see the echo? We have the echo here too.
Were you able to see a pericardial effusion by echocardiogram?
See a pericardial effusion?
No, and there wasn't really much on. There wasn't hardly any on the MRI. There was none.
Let's see the echo here.
Very trivial.
Let's see. Hang on here. We'll get the echo up. I think we have Jonathan online now. I don't think he's entered his PIN though. But Jonathan is here now. Dr. Angelini, we have Jonathan here.
I can see you.
Yeah, Jonathan Tobis is here now. Okay.
All right. Are we finished or should we continue?
We're gonna get the echo up.
All right.
You see that? So just hang on for a minute.
I had a standby case in case your presentation was short, but evidently we'll leave it for the next time.
That'll be fine.
It was a quite surprising case in an athlete again.
Well, we love your
Anomaly.
We love your surprises in athletes. Those are our favorites.
Exactly.
All right, so here we're going to get some echoes up for you.
We leave it for April. No, for May.
Great.
So is this the gentleman with football player?
No, a new one. So which echo you want to start with? March 23rd? March 20th. Here we go. 19th. You have the 19th. Here we go. Let's start with this one. And we'll bring this up. This was the echo that we did as actually the echo tech herself, during the Takotsubo, did an echocardiogram on herself.
Did she make the diagnosis on herself?
She participated in the making of the diagnosis and was relieved to know that she wasn't having a heart attack in terms of coronary artery disease.
That's very good.
She was very happy about that.
Excellent.
20th is a proper echo when I got out of
Yep.
hospital.
Okay. She was in the hospital overnight, and then basically decided they couldn't keep her there any longer because she was going stir crazy.
Would you call this pericarditis?
I didn't.
A little bit.
Ooh. Tell me how.
Yeah, so we just show you this, and the pericarditis was symptomatically, it sounded like pericarditis. Certainly, well, a lot of changes in contingent adjacent leads on the EKG. Symptomatically, you have to call it pericarditis. And then we nailed it down when we got the MRI with lighting up of the pericardium is classic. And then we can move on to the next echo. And we have serial echoes daily. It's we'll just skip a couple days and move to the 24th.
You see pericardial fluid anteriorly or nothing?
I don't see anything on this one.
She's got prominent epicardial fat with no confusion.
All right.
So let's go to the next one. Let's go jump to the 27th. We'll do every couple days here. Don't want to bore you. It's beating much more vigorously in the non-affected segments. It appears that there has been improvement. This is on the 27th, so that's like 8 days. We've already seen dramatic improvement working from the base to the apex.
All right.
Let's go to final echo. Looks like we have April the 7th, which is
20
a
days.
few days ago.
That looks good.
Normal.
Yep.
Oh, that mid wall looks a little bit.
Looks very good to me.
Excellent.
So let's see if...
Eric, if you have a minute, I'd like to ask you a question.
Yes, go ahead.
It's about MRI and tattoos. You know what tattoos are? Painting of the skin with tattoos is supposed to be a...
Okay, tattoos, it's supposed to be a contraindication if you have metallic ink. And you have to distinguish if there's metallic ink. Otherwise, you can get a problem. But you can send the patient to get lasered and then return for the MRI, since we're very committed to doing MRI. You could analyze, you could put something over it, like we have these magnetic sensors that we test people for metal detectors, and if it's positive, then it's contraindicated. If it's negative, it's not.
Like a magnet?
Yeah, sir. Well, we have a metal detector that we use, and if the metal detector is only for ferromagnetic material, and so that'll beep. And so we pass that over the person's body and over the tattoo, and if it's positive, then we know it's ferromagnetic.
It quantitates the amount of iron, or it's positive or negative?
I suspect it's only positive or negative rather than quantifying.
So it's very simple, and it can be done in the MRI suite.
Yeah, very simple. We always do that. We have it available at all times, and anytime we have visitors or patients that we're unsure of, we pass it over them. And MRI is divided into zones in its position in the hospital. So you'll have zone 1, which is immediate contiguous, and then we have zone 2, that's within about 20 or 30 feet, and then we got zone 3, that's within about 100 feet. And this is one of the things that's mandated that you have available, because people will try to bring wheelchairs in, they'll try to bring ferromagnetic oxygen tanks in, and so we've got to be ever vigilant. And then people will say, oh, this is not ferromagnetic, and we'll say, we'll check and see, and so forth.
I was explained by experts in the business that ferromagnetic tattoos are not used since 20 years ago. Is that true, or do you know? Do you have any idea?
I don't know about that, but I do know that we have a lot of people that from World War II, and we got these old people in their 80s, and we got people from Vietnam, Korea, and so we have a big military base here. It's MacDill Air Force Base, and so people come down here to retire and then use the commissary, and so we see a lot of retirees from the military. So those are the people that we'd be checking. As far as young people, I don't know, but I can look that up for you because I have some tattoo people that I know.
This is a question that comes for the IRB that controls our MRI screening of kids,
Yes.
11 to 18-year-old. We finished the first 4,000 cases below age 15, and tattoos were very rare. But now in the high school, tattoos become more than 50% of the cases in the schools. And I am not aware that this is an objection, but there is a question with the IRB if or not we should do. But what you suggest to use a metal detector is very good. Is it written anywhere in any recommendations of radiological societies in this regard?
There are very stringent state rules for MRI, and that involves setting up the zones. It involves checking anything that comes into the area.
But is any recommendation stating that a negative metal detector test is enough to rule out the possibility of side effects?
Yeah, I don't know that. Don't know that, but let's look. See what we have of ferromagnetic.
But you gave me a very good idea, and we'll propose it.
Yeah, we can look at. Here's the girl with the ferromagnetic tattoo. That's pretty interesting. And they vibrate your skin in response to telephone calls, it says here. That ferromagnetic vibrations of your skin occur in response to calls and texts, so you can have skin-sensitive text messaging.
Huh.
So that's kind of interesting. It may also be that different countries have use of this ferromagnetic ink, and so you can't be sure just in the United States. If you see somebody from Japan or from some other place, you need to check again. But
are you aware what kind of reaction if there should be ferromagnetic pigment, like heating, overheating of the skin, or also something structural and important?
yeah, let's see.
At this time, what I hear that the radiologists do is to alert the patient to say, if you're not sure, but you feel heating of the skin during the procedure, you let us know and we'll stop. And that has never brought to any consequence of clinical relevance. But is this the practice in your place too?
Well, here's what it says here on this information. It says that the skin doesn't get sucked off is the first thing. And then second is they may feel some skin discomfort if they're old metallic tattoos. And so basically you're supposed to indicate that you feel something. I've had people that feel something with their dental amalgams, and they've said my teeth hurt, and but there's been no consequences. The teeth don't get hot, but they do. You do have hurting of your teeth, and so that's also been a problem. Sometimes the tattoo artist may have left a piece of metal in you, and so you never know what's happened, and so everyone needs to be checked all the time. And I'm sorry that the majority of people now have tattoos, and that us untattooed are in the minority. But now that there's a cure for hepatitis C, maybe it's okay.
All right.
It says some of the ink used in prison tattoos contains heavy metals, and so if you have the prisoners with the teardrops for the number of murders they committed on their skin, that may be a problem.
Huh.
So I think Jonathan logged in, but he never turned in his PIN number and never was ever to speak. We do have a guest by the name of John Fay, who's training in hospital and medical administrative facilities, and he came online today, and I'll unmute John so that he can speak. Hello, John. We appreciate your coming to our conference today. And John is learning about being a cardiology administrator from monitoring some of our cardiac activities. So, Paulo, thank you so much for coming. We appreciate it. We look forward to our next conference in May.
Thank you very much, Eric.
Yeah, appreciate it.
Thank you also for the help with the iron.
Yeah, bye-bye. Bye-bye, John. We'll see you later.
We can comment on, the previous studies that are out, and then,